And now we go on to the second speaker, who is Professor Julienne Meyer, who is a professor of nursing in London and works from the City University. She's got a particular interest in patient involvement, and she has researched in an area that is somewhat neglected, like care homes and areas that haven't always had the attention they might deserve. Professor Meyer.
Thank you. Well, I just want to begin by thanking you for inviting me to come and speak to you today. Patient participation is in my being. It was the focus of my PhD, and it's absolutely core and central to my work. And I want to thank you for the amazing work that you do, but also to thank Patricia Wilkie, who invited me. It's payback time. She's done so much for me over the years. I'm extraordinarily grateful. What matters to you, medicine, not what's the matter with you. I've really got hold of that, and I think that probably is at the core of what we're trying to do in my home life. And I think my key message, following on from what Dr. Campbell has said, is please don't forget care homes in your work. Because when you talk about accessibility, treatment, depth, efficiency, fairness, care homes are not getting it. Frail older people in care homes are not receiving the same care that they would if they were in their own homes. So that's my message. Don't forget care homes. And I think part of the problem is we've talked about primary care being in crisis. I think what I've seen over the years is care for older people being given away. What I thought was nursing is now predominantly the work of the social care workforce, and actually care homes have taken on an extraordinary amount of work over the years in caring for older people. And I think what's happening, they've been in crisis for decades, and I think what we're seeing now is a sort of damming back up, and the NHS is seen in crisis, primary care is seen in crisis, and I think this is because the whole system is. So, I'm here to talk to you about the work that I do in care homes. It's not the only area that I work, but it is the work that I've become most known for, in particular over the last 10 years. And I'm the sort of researcher who works at the development end of a research and development spectrum. I'm very interested in working with people out there in practice, feeding back to them what older people say about their services, and then working with them on changing practice. And the research bit are just what are the lessons learnt from those attempts to improve practice. So what I want to do is just quickly go through the context of care homes, because I think they are islands of the old, people forget about them, and actually I think we're all quite ignorant of what this particular sector. I'll tell you a little bit about My Home Life, which is a UK-wide initiative to promote quality of life in care homes that is a collaboration between City University and Age UK. I want to flag up what is best practice in care homes and just share some lessons learnt from the work that we've been doing over the last 10 years. And I just want to leave a thought with you about perhaps how you might wish to engage going forward with care homes or not. But I think we should begin with the context, and we should ask ourselves, what do we think about care homes? And I think care homes get negatively portrayed by the media, and I think the public generally have a very negative stereotype view of them. What do we know? Well, there's approximately 18,000 care homes for older people. What I don't think people know is only approximately 5,000 are registered for nursing. So most of these care homes do not have a health professional working directly inside them. Another fact I don't think people know is that when you compare the number of beds in care homes with the whole of the NHS, there are more than 3 times the number of beds. So this sector is huge. It's 90% independently owned, and I don't know whether you recall that older people used to be cared for in hospitals, and then in the mid sort of 1980s, they went out into the community, and this was when we saw the growth of care homes. At the same time, they redefined what nursing was, and as I say, what I had been brought up to think of as nursing was in terms of care for older people, was given away to the social care sector. Dementia used to be mental health nurse specialism. it's now predominantly a social care issue. And I think what we saw at that time was the privatisation, the covert privatisation of a whole section of the NHS. And I think we have to recognise that the care home sector is 90% independently owned. They're not all for profit. There are some that are not for profit. And we have to see that it's a very heterogeneous sector. You can't make any generalisations about them. Some large corporate groups, but there are some ma and pa homes. There are some with 100 beds. There are some with just 2 beds. So we can't make any assumptions. Being cared for in care homes are 405,000 older people with an average age of 85. Now, you have to, because the policy focuses on care in your own home, people are now going into care homes later, sicker and more frail. And what you're finding is that what used to look like a nursing home today, compared to 5-10 years ago, now looks like a mini hospital. What used to be a residential care home today now looks like a nursing home used to look 5-10 years ago, because people are going in later, sicker, frailer. So there's a huge increase in healthcare need in care homes, but the workforce has not changed. So we've got a lot of cognitive impairment, depression, and 75% classified as severely disabled. So something's got to be done. When you look at the funding, there are huge inequities. So if you look at what a local authority on average will pay per week for care, it's way under what the cost of care is, and it bears no comparison to a hospital bed, what we would pay for a child in residential care, or somebody who might have learning disabilities. I don't think the public realise that 41% of people in care homes are paying for their own care. And that 28% are paying for top-up. So actually this sector is saving a huge amount of money for the NHS, because in the past it was the NHS who cared for these people. Let's look at the workforce. 500,000 are employed in care homes, and yet they're paid less than the people who look after our rubbish, less than the checkout desk of Tesco's. There is no funding often for their training, and actually the educational level is pretty minimal. And this sector feels very unappreciated, undervalued, and unsupported. So I think in terms of context, we have to recognise people are going in later, they've got more health problems. Care homes are caring for some of the most vulnerable citizens in our society, and they are making a significant contribution. And you hear politicians say that in the future we won't need care homes. Dream on. They're projected, with the ageing population, they're projected to increase, not decrease. Not paid a fair rate for care, it's mainly a social care workforce. And we have to do something. Either we have to skill up that workforce in health-related skills, or the NHS has to work in better partnership with them. So I want to talk to you about the initiative that I'm involved in that started 10 years ago. And we're all about promoting quality of life for those living and dying. We have to recognise that most people now, probably on average 1 year in a care home. What's the difference between care homes and hospices is something we have to start asking ourselves. But we can't just focus on the older people in the care home. We must also focus on the relatives who visit and the staff who work. So looking back, we had no idea where we were going, but we can sort of package it up retrospectively. And I think the first phase of my home life was funded by Help the Aged, and it was all about bringing together what do we know older people want and what works in care homes. So it's pulling together the evidence base. The second one was funded by BUPA, and this was about getting the messages out to the care home sector. And they're not going to read our academic articles, this social care workforce. We've got to think about how we communicate with them in a different way. So storytelling is key in illustrating the evidence base. And if you go on our website, you'll find lots of resources, all freely downloadable films. And we always tell the stories from the perspective of residents, relatives and staff. The third phase, funded by Joseph Rowntree and others, was when they said, we like how you're working with care homes. find out what support they need to put this evidence into practice. And we've developed a leadership support programme for the care home sector. And then finally, more recently, we've been funded to look at how can we help sustain My Home Life going forward, but actually really how can we open up the doors of care homes so that they are seen more as part of their local community and not islands of the old. So this small project has sort of grown gradually into what's now being described as a social movement. So it's gone across national borders. There are initiatives in Wales, Scotland and Northern Ireland. We're talking with Australia, Iceland, Germany. There's something going on here, and I think it's quite interesting to just think about, well, what is it that's going on? And I think what it is the thing that glues us together is this evidence-based vision. And I want to talk you briefly through it, but I want to say I don't think this vision is just for care homes. I don't think it is even about older people. It's a common sense vision. And on your tables, I've left you a flyer that sort of gives details of it. And I'm just going to talk very quickly and briefly over it. But when you think about what matters to you medicine, not what's the matter with you, I think this helps deliver that. So the focus here is not just on residents, relatives and staff, it's also on how care homes connect with their local community, but also the wider health and social care system. And when we pulled the evidence base together and developed best practice together, it clustered around 8 themes. And those 8 themes, you can see divide into personalisation themes, navigation themes and transformation themes. Sorry about the language. But actually, the common sense principles here are the transformation themes are what we need to do, what the care home managers need to do to support their staff deliver the other 6 themes. And this is all about how do we keep the workforce fit for purpose? How do we promote positive cultures in which change will happen? But I think it's the other 6 themes that are really key here because we work in silos. And I would argue that social care, social work tend to focus on the personalisation themes. Maintaining identity, see who I am, sharing decision making, involve me, creating community, connect with me. Whereas the health people tend to focus on the navigation themes, how we manage transitions, maybe into and out of a care home, but not just the into and out of, the managing how we're adapting to our frailing bodies, frailing minds. Improving health and healthcare speaks for itself and supporting good end of life. But I think the issue here is that older people want all of this. They don't just want one part of it. And I think the reason why we have the need for things like a dignity strategy in the NHS is because we've lost the personalisation emphasis. It's our approach that's missing. So I get assistants saying of nurses who work in care homes, if only those nurses would realise that this care home is someone's own home, it's not a clinic, then the resident would have a better quality of life. Whereas I get the nurses saying of the care assistants, if only they would push fluids more, then actually the resident would wake up and they'd have a better quality of life. There's something about silo thinking, and we've got to think about all of these themes. The focus on relationships. Person-centred care in policy focuses on individuals, independence and choice. Now, great though that is, in this setting, frail older people actually need interdependence. It's about relationships. And unless we address the needs of residents, relatives and staff and make all 3 groups feel good about visiting or working or living and dying in care homes, then we will not actually end up with person-centred care. And so we draw a lot on our work of appreciative inquiry. I always say as a researcher, I'm sick of the research that focuses on poor practice and blames. Why don't we focus on what we know people want and what works and share that? So we try to change the language, and that takes us on to having caring conversations, which is based on work that's actually come out of a PhD using appreciative inquiry in the NHS context. And I think it's actually really quite helpful. I always taught communication skills when I was teaching at King's College, and it was all about non-verbal and verbal. It was all about open questions and that sort of thing. I think this takes us on a step further, and it fits with what you're talking about. So, for instance, in this framework, helping people to ask courageous questions, take risks. What would happen if we gave this a go? Helping people to connect emotionally, deliberately ask about feelings. I love this one. It's a curiosity question. Helping people to not blame or judge, but just say, help me to understand why you said that, why you're doing it. Collaborate. Helping people to ask, what can we do together to take this forward? Consider other perspectives speaks for itself. Compromise. I don't think we do that enough. And the big one also, celebrating. We really need to change the language of negativity. So that's at the core of my home life. And I don't think it's about care homes. I don't think it's about older people. I think it's a common sense vision that we could all keep in mind. So in terms, drop my watch. In terms of the work that I do in a university with my home life, it's research, enterprise and social action. So if you're interested in the research side, on the website, there's lots of research that we have done, but also research that's been done on my home life, and I won't bore you with it. I think you'll be more interested in the enterprise work, and in the enterprise work, we're bringing care home managers in local areas together, and we're creating a safe environment in which they can actually learn from each other. They're very isolated, and we help them to talk. And we do that by giving them some fun exercises to do that helps them think about the evidence base for best practice, helps them think about the importance of relationships, helps them to see their pivotal role as a change agent and to recognise their own leadership style and think about how they might do it different, perhaps. And this programme then helps over the course of a year to support care home managers take forward quality improvement in their homes through action learning. And action learning is when they come in and each one of them, in turn, has an hour to present an issue of concern to them, and then the others question them about what they might wish to do about the issue that they're troubling. And it is through those questioning in the action learning that people learn to change how they talk. And what they're saying is they're then taking that back into the care home. It changes how they talk with staff, and that they're claiming that this then influences how their staff then work with residents and relatives. The community development strand is really about how we help care homes then work with their wider health and social care system and also their local community. And often what we find is that they talk about the same sorts of things. They talk about quality monitoring, safeguarding issues, avoidable hospital admission. And when we find something that the care homes are concerned locally about, and the funder, who's usually a local authority or a CCG or whatever, when we find something they're both interested in, we bring them together. We use appreciative methods to help them understand each other's context better, value and respect each other more, and to use appreciative methods to see what they can do about an issue of concern for them. And really all we're doing is through that process, hopefully leaving them in a place of better partnership working. On the social action side, as I say, we're trying to help care homes open up their doors to their local communities. And the initiative itself got special mention in the white paper, and I'm not saying that to say, you know, look at us, we're great. I'm just saying I think there's some really useful thinking behind this that's worth taking notice of. So what are the lessons learned? This, I think, is about not doing different things, but doing things differently. And we encourage people to think about that from board to bedside. For me, it is about blurring the boundaries between research, education, and practice. And it is about being evidence-based, relationship-centred, appreciative, and focused on action. So my thoughts for you today are, how is NAP working with care homes? What is working well, but what more could be done? And what support is needed to help this happen more of the time? please do get in touch or look on the website if you want to know anything more about this. And I look forward to hearing your comments. Thank you.
Thank you very much indeed, Professor Meyer, and running so beautifully to time. We've got time for a few questions for Professor Meyer, if anybody would like. Please stand, give your background, and the microphone is on its way.
Thank you. Jeffrey Austin, Patients Group of Bacon Lane Surgery, Edgware. In your experience, in the homes, are there any Darby and Joan patients groups that in fact encompass relatives and staff?
Yeah. I think it's getting better. Some care homes do have relatives and resident groups. I think there are challenges, and I'll give you one example. A fantastic care home up in Aberdeen. She started with a relatives and residents group and actually found it didn't work, and that was largely because these frail older people had sensory impairments and found it quite hard to work in a group. So what she's done is actually have meal times where residents, relatives and staff sit down together and share a meal. And she says it's through these informal conversations that they come to know more about what people want, and that is feeding into their plans for improvement. So yes, care homes do have relatives and residents groups, but not all. And actually, I have no idea how many do, because it's such a heterogeneous group that there's no way of knowing. It's only recently that we've got any real data on who works in care homes, and that's because people have volunteered to give data to the National Skills Academy. So we've got a better understanding now of the workforce. We didn't have it before. It's so outwith of the system.
Hi, I'm Margaret Luxton from Albany House, PPG in Wellingborough in Northamptonshire. And our GPs do a ward round in the mornings of the local care homes. They call it the ward round. And the local Wellingborough Health Group, which is part of the CCG, are trying to get doctor's surgery to look after 1 or 2 or 3 homes rather than have all the different surgeries going in to... Is that countrywide, or is that just something that they're doing in my local area? So that one GP surgery looks after one care home, or several care homes, but it's one surgery instead of all the different surgeries bobbing in to see
the current state of affairs is that you often have, that the resident is able to choose which GP they want to stay connected with, and you often have lots of GPs coming in, although some care homes actually employ GPs to come in, and other care homes have GPs locally who have done, as you have done, formed a relationship with the care home and now do regular visits. Not sure about the sort of ward round idea in a care home, but hey, I'm sure it's not really like that. But what we know is there's a real fundamental problem about general practice in care homes, and you've probably read about it in the newspapers more recently. People in care homes don't have the same access to health care and services that they would if they were in their own home. It's a problem. And I've just finished supervising a PhD of a district nurse who was troubling whether people with dementia in residential care homes, how their physical needs were being met and whether they were being met. And it was quite interesting. Her findings came out looking back at the district nursing service rather than the care home sector. What she found was that actually district nurses are thinking that the residents in care homes are safe and that they've got access to healthcare. So they send the more junior person in, and this junior person goes in maybe to do a simple dressing. And the person with dementia doesn't want a dressing done from a complete stranger at the moment that is convenient for them to do it. And so often the dressing doesn't get done, and the district nursing assistant leaves. And what's this telling us is we have to think about and change the way we work. You know, really it should be the most expert district nurse going in. She should be educating and supporting the care home staff to actually carry out the dressing, because the person with dementia wants it from somebody that they know and at a time when they're ready for it. We all have to rethink how we engage with care homes.
Anne Rendell, Alma Lodge practice in the Wyre Forest. Do you think that the amalgamation of the welfare and or social and welfare budget and the NHS budget is going to be a positive catalyst towards what you're suggesting, that you will get eventually? I mean, the Manchester project is probably just starting now. I should imagine all eyes are in that direction. But do you think that it's going to be too late now for these care homes that we're losing? Too little, too late?
We heard about the 5-year forward view, and one of the key strands is enhanced health in care homes. And I am joyous that finally we've got policy that's actively encouraging the NHS and local authorities to work in better partnership with care homes. There's so much that needs to be done. Is it too late? Is there not enough money to fix some of the problems? I don't know. But at least for the first time, I feel there is the willingness to start to talk. And that's what needs to happen.
Hello, I'm from the Farringdon White Horse Medical Practice. I'm on the PPG. I just wondered, when I was a nursing, we found that the pharmacists were a very good source of, when they used to come around the community hospitals, they would update a lot of the medical, the drug charts. And I was just wondering whether in the nursing homes they could do this, because of all the medicines that the old people are on, causing a lot of problems, and it might solve some things and the GPs wouldn't have to go around. Is there any evidence of this?
Again, pharmacists are like GPs. Some are going in and have good relationships with care homes. There are others that never see their pharmacist, and there are some care homes that pay the pharmacist to come in. It is hugely variable. But actually, are residents having their medications reviewed enough? Probably not.
Francis Brown, Priory Avenue at PPG in Reading. And my question is about training. Our CCG has paid for training for primary care nursing, and that's been very helpful locally. Are there any examples where CCGs have paid for upskilling of the staff in care homes?
Yeah, it's really interesting that you asked that question, because I think we are seeing people view care homes as part of the solution to some of the problems in the NHS. What I would say over the 10 years is that care homes have not had access to training, but more recently that is starting to come through. But the issue is not really just about access to training. Releasing staff to go to training is a real problem when you're not paid a fair rate for care. And some of the care workers are actually doing the training in their own time and at their own cost. The issues around training are huge.
Sue Knox from Gloucestershire. It was really just in response to the other lady's question. In Gloucestershire, we've got a really good project going on, which is called the Farm Care Project, and it's a social services and NHS-funded project where pharmacists are going into care homes and they are reviewing the medication in conjunction with an enhanced service that the GPs are being paid for, whereby every resident gets 2 medication reviews per year. And that project has not only saved a massive amount of money off the prescribing budget, it has actually reduced the falls risk of a lot of residents who've been over-medicated, who've been coming in on very strong opioid analgesics and other drugs that are causing them to be at risk of falls. So it's a very successful project. I'm happy to talk to anybody about it later.
So to round up, thank you for that comment. It's beautiful to end there. Don't forget care homes. What we've just heard is that when you do work with care homes, there are some remarkable things that can happen. So thank you for that.
Well, thank you very much, Professor Meyer.